Good afternoon, everybody. I'm Dr. Pratik Tambe, Governing Council member of ICOG and Chairperson for a Mobile Technology Committee. Welcome to today's event, which is the next in the TOG Experience series. We've had a series of events in this series which are highlighting the fetus specifically and the issues related to perinatal morbidity and mortality. And today we have two illustrious speakers in the shape of Dr. Alpesh Gandhi, sir, our past president of TOXI, and Dr. Anjana Khanna, our past vice president of TOXI. We'll be speaking about two very distinct and unique topics. But before we hand over to the chairpersons, I think I should formally introduce the chairpersons first. Next slide, please. I'm delighted to welcome our very own Dr. Sarita Bhalerao, madam. She is recently been elected the secretary-elect of ICOG. She's been a governing council member of ICOG, of course, in the past 5 years. She served as the president of the Mumbai Society in 2021, joint secretary of Foxy in 2017, when Dr. Ishma Devantai was the president. She's also the past president of ANWI Mumbai branch and the chair for the AICC RCOG West Zone. Madam is driving. She will be logging in very soon, and we hope to see her very soon. Next slide, please. I'd also like to introduce Dr. Hafizur Rahman. Sir is a professor of OBGYN and a co-governing council member of ICAG along with me. He has over 65 scientific research publications in national and international index journals, peer reviewer on the board of several journals. He's won the Foxy Future Award in 2017, several other Foxy awards to his credit. We are very happy to have Sir with us because it's a working day and in the afternoons, I'm sure he must be at work at the medical college. So thank you for sparing your precious time and being with us. Without further ado, I'd like to hand over to Dr. Hafizur and I would request him to please introduce our first speaker, Dr. Alpesh Gandhi, sir. Yeah, Dr. Hafizur, please go ahead.
Madam. So today we are having with this is very important times of gynecology series where we hardly give focus on that is fetus focus. So today our important topic is the fetus. So we have this research Imin and Alpesh Gandhi sir, that is he need introduction, but still for take that is need to tell. Sir had been president in 2020 when the COVID came. And when almost the entire world stopped, but still the academics were the effort and all the steps by Gandhi sir. So he has been the resource person for GCP around and COVID-19. And with the COVID-19, even for the neonatal registry and resource person in so many speaker in obstetrics and sir has also contributed his own principles of critical care in obstetrics and gynecology. He has awarded him with honorary FRCOG and Best Society, Best RCS Activity, and Best Publication Award from Foxy. So he has been the convener of the most successful AICG 2017. So sir has been practicing in
I think Hafizur has some internet issues. I think we should go ahead with the first speaker, requesting Dr. Alpesh Gandhi sir to please share his screen. Get started.
yeah. So I would like to hear Alpesh Gandhi sir.
Thank you very much for the kind introduction and inviting me for this very important meeting and important topic. I am thankful to all the organizers for giving me this opportunity. I can see Dr. Pratik is sitting like in a corporate office, a very good backdrop with him, and he is drinking coffee, and he has not sent coffee for me. So without coffee, I am going to present my topic, and I'm two dear chairpersons, Dr. Sarita and Hafizur. My regards to you, I'm coming to my topic. I'm going to speak on a topic that is neuroprotection, the obstetrician's perspective. That is very, very important. And 1 minute. Yeah. So in next 20 minutes, we'll see why it is important, what is our perspective, and what we can do for the fetal neuroprotection. So to begin with, when this is a very famous movie and very famous ship, Titanic, when it has started its maiden journey for the first time, there was an atmosphere of celebration. Everybody were excited. There was so much happiness. They were greeting each other and they were ready for the journey. So similarly, when pregnancy is, when we identify pregnancy, when the family members come to know that she is pregnant, there is all are excited in the family. There is happiness. They are celebrating the news and they are waiting for the new comer to their family. But and like this, they all are enjoying in the family. But when suddenly, if any complication occurs during pregnancy, then they all are worried. The anxiety turned into the happiness turned into anxiety, and they all are worried very much what will be happen to the mother and what will happen to the fetus baby. Similarly, and at the same time, when this, any complication occurs, immediately we need to take some life-saving measures like the jackets and lifeboats and like that. So we have to be very much aware. We have to be very much alert, and immediately we need to take some actions to prevent the disaster in the family. Otherwise, it can lead to the disaster. We may lose mother or baby or both. So many complications can occur. So we should always keep our setup ready. We should always suspicious it. We should always try to predict it. We should always try to identify high risk mother who is going to have this problem, and we should always keep our setup ready. We should always we should continue counseling with the patient and her relatives, and we should also train our staff to tackle any such disaster. And preterm labor is very much one such type of disaster where we can where the fetus, the baby, newborn, newcomer going to the family can be at a very high risk. And so we always should have suspicious, and we should always try to save such type of disaster. So at the beginning, very briefly, I would only like to mention about what is preterm labor. Then preterm labor is defined as regular uterine contraction that occur between 20 to 37 weeks of gestation and are associated with cervical changes. When it occurs before 28 weeks, then it is considered as the extremely preterm. When it occurs between 28 weeks to 33 weeks and 6 days, then it is early preterm. And when it occurs between 34 to 37 weeks, it is considered as the late preterm. And the complication related to this extreme preterm, early preterm, and late preterm are also differ, and particularly severity is differing. Why it is important to manage preterm delivery? Because 120 million babies are born every year in the world by preterm delivery. Out of these, 2 million baby die in the first 4 weeks of their lives, and that is, we can say, neonatal period. The three main direct causes of neonatal death globally are preterm birth, severe infection, and asphyxia. Half of the babies, preterm baby, who survive after the preterm birth may develop long-term neurological disability, may face CP, may have learning disability, visual or hearing problem, and many other neurological problems they can develop. Unfortunately, as per the 2022 WHO statement, India is one of the country. India is the country having the highest number of preterm delivery across the world. As per the WHO 2022, 3.5 million babies are born preterm in India. So it's a substantially high number, though there is a a very good improvement in India, but still high number of preterm babies are delivered every year. And India, again, sad part is not only the preterm birth, but the death because of the prematurity is also highest in India in the world. 35 lakh infant in India are born premature. Out of these, 3 lakh babies die due to complications of prematurity, and those who delivered between 500 to 999 gram may require NICU stay for 30 to 40 days. Those who delivered with birth weight of 1,215 gram may require NICU stay for 15 to 20 days, and this leads to a great financial burden to the family, to the healthcare sector of the country, and further they may develop neurodevelopment. There may be a neurodevelopment impairment in survivor, which may add further economical burden to the country. So when prematurity, when preterm delivery is there, it can lead to neonatal death, intraventricular hemorrhage, cerebral palsy, ARDS, necrotizing enterocolitis, jaundice, infection. It can lead to retinopathy of prematurity. It can lead to hypothermia, hypoglycemia, and many behavioral problems can occur to the neonates. So many complications can occur, and preterm, they are having a higher chance of dying in the first few weeks of life, and when they survive, as I mentioned, neurological impairments means it can lead to cerebral palsy, cognitive dysfunction, educational difficulties, psychiatric disorders can occur in the adulthood with increased, of course, educational and societal cost. These are the high risk. I am not going in detail. We have to identify this high risk factor, and we should offer screening to prevent preterm delivery, to predict preterm delivery and prevent it. We should offer the screening to all by identifying the modifiable risk factor, non-modifiable risk factor, and offering cervical length measurement to all while performing sonography between 18 to 22 weeks scan. And those who are at a higher risk having a uterine anomaly or previous preterm delivery, history of preterm previous delivery, should offer cervical length measurement from 14 weeks onwards, and we should do per speculum examination for the screening for vaginal infection and bacterial vaginosis. But the important thing is, once we come to know that this mother is high risk for the preterm delivery, we should do counseling. And when she is imminent to preterm delivery, when we think that this mother is going to be delivered within 24 hours, in spite of all the measures taken, I think Dr. Ranjana is going to speak on all these measures, what should be done to prevent preterm delivery. So, but when we come to know that she is going to deliver now within immediate period, within, we can say, in 24 hours, then another important role of obstetrician is our worrying always about this neurodevelopmental problem, and we can play a significant role in preventing some of these problems and can help the newborn. So what we can do is, the MACSELF is has a very magic role. We can see it has a very significant effect on neurodevelopment problems. Of course, it has it can be helpful in hypertensive disorder in pregnancy. Of course, it is not the drug of choice, but it has some effect on hypertension disorder in pregnancy. It is the drug of choice for the imminent eclampsia. It can have a role in preterm labor. It can also be helpful in preventing preterm labor for few hours or few days. So, but here we are interested in discussing its role in fetal neuroprotection. So it has other significant role in HDP, imminent eclampsia, preterm labor. But one important role is fetal neuroprotection. So when preterm labor refers to progressive, as we have discussed, when there is a cervical dilatation, progressive cervical dilatation or effacement associated with regular uterine contractions, and when we are thinking this patient is going to be delivered within few hours or within a day or two, then there we may need prophylactics are used to delay the active phase of labor for at least 48 hours, maybe because of some, of course, steroid might have been given before or not given. We may want some time to give steroid. So there, or we may need to ship the patient to the tertiary care center where NICU facility is there. So for so many reasons, we need to prevent or we want to delay the active phase of labor for few hours by using tocolytics and magnesium sulfate, prostaglandin inhibitors, calcium channel blockers, and nitric oxide releasing drugs have shown benefit in this woman. The use of tocolytics such as magnesium sulfate in preterm labor is well established, and we'll see next few slides how it is helpful and which what are the studies. So first report of Maxalf as a tocolytic was published in 1977. Which was followed by the largest case series in the literature in 1983, where 355 patients were treated with Maxalf as a tocolytics. Patient had multiple other morbidities such as amnionitis, placenta abruption, premature rupture of membrane. In this study, the finding were in singleton gestation with intact membrane, 76% of these patients' mothers gained 48 hours before delivery, 51% gained 7 days, 1 week, and 39 achieved a full-term delivery with the role of magnesium sulfate as a tocolytic. So it has significant role in preventing preterm delivery, in preventing active phase of preterm labor for 48 hours or up to 7 days. Another study was published where Maxalf was compared with the placebo. In this study, the aim to investigate the effects of magnesium sulfate on delay in reaching the active phase of labor in women with premature rupture of membrane and subsequent fetal complication. 92 women were divided into two groups. In one intervention group, Maxalf was given. In another group, it was considered a placebo group, and Maxalf was not given. Maxalf was given in the dose of 4 grams of magnesium sulfate was dissolved in 100 ml of normal saline solution and administered intravenously over 20 minutes. After that, 2 grams of Maxalf dissolved in 100 milliliter of normal saline per hour given by infusion. The infusion was continued for 24 hours after complete cessation of uterine contractions. Both groups received corticosteroids, and antibiotics were also given, azithromycin, ampicillin, and amoxicillin were given in different cases or an additional 5 days. And the findings were Maxalf was a delay in delivery for at least 48 hours. Magnesium sulfate increases this period 2.7 times the same as in control group, which we can see in this graph. As at the gestational age, when it was less than 30 weeks, magnesium sulfate led to delay in 77% of the cases, 77% of women, 87.7%. At least 87.7% at 30 to 31 weeks and 72.7% at 32 to 33 weeks of gestational age. The result was the chance of respiratory distress syndrome in infants who had received magnesium sulfate was 80% less than those who had received placebo, and there was no case of chorioamnionitis or adverse effect reported. The conclusion of this study was magnesium sulfate delays the active phase of labor in mothers with PROM and prevents adverse birth outcomes. Again, this 192 women in active preterm labor were given Maxalf versus nifedipine study was conducted. And these mothers were between 24 to 33 weeks of gestation. All patients received betamethasone and antibiotic, and they were divided into two groups. One intervention group which has received Maxelf, and another group nifedipine was given as tocolytics. Maxelf was given 4 gram bolus. Maxelf was given, followed by a maintenance dose of 1 gram per hour. Physicians were allowed to give additional 2 gram magnesium sulfate boluses as if needed, and to increase the infusion rate up to 4 gram per hour if required. In nifedipine group, 10 milligrams sublingually was given every 20 minutes for 3 doses total, and then followed by 20 milligram orally for 4 to 6 hours based on clinician's judgment. The primary outcome was arrest of preterm labor, defined as prevention of delivery for 48 hours with uterine activity were stopped. When it was compared, then the arrest of preterm labor was 87% in case of Maxelf, and in case of the group in which Maxelf was given to mothers, and in nifedipine group, arrest of preterm labor was observed in 72% of the mothers. All other parameters like gestational age at delivery, delivery in 48 hours, neonatal outcomes were similar between these two groups. So conclusion was patients who received magnesium sulfate achieved the primary outcome more frequently. Again, the inhibits uterine contractions and delays delivery by delaying the active phase of labor. Maxelf can arrest preterm labor, significantly reduces the incidence of respiratory distress syndrome, and babies born preterm compared with those born at term have a higher chance of dying in the first few weeks of life, as already discussed. But those who survive can have neurological impairment, already we had discussed. And antenatal magnesium sulfate is recommended for neuroprotection of the fetus in women at risk of preterm birth, because we want to prevent this neurological impairment. And magnesium sulfate, antenatal magnesium sulfate, is found to be very useful and has effective role in preventing neurological impairment as the neuroprotection of the fetus. When preterm delivery occurs, it can lead to two types of CNS injuries. Pathologically, it can be intraventricular hemorrhage, usually diagnosed by ultrasound, or it can have white matter injury, which can be diagnosed by MRI. Clinically, the most frequent adverse CNS outcomes in preterm delivery are cerebral palsy, cognitive impairment, blindness, deafness, and developmental delay. We want to prevent all such type of complications. So coming to cerebral palsy is a disease that affects movement, muscle tone, motor skills. The incidence is 1.5 to more than 4 per 1,000 live births or children of a defined age range. And again, sad part is the incidence of cerebral palsy increases because due to increased survival of preterm infant. Now, mortality, neonatal mortality, because preterm delivery is decreasing, but at the same time they are survived, and when there is surviving, and half of these babies may develop, those who survive the preterm labor may develop neurological problems and may develop cerebral palsy. So the incidence of cerebral palsy increases also. Injury to developing brain can occur at any time during prenatal period, perinatal period, or even during postnatal period. During prenatal period, maybe because of the rubella or cytomegalovirus infection, or maybe because of the blood or oxygen delivery to the fetus is reduced, or during perinatal period, maybe because of the birth defects, maybe because of the preterm birth, maybe because of the intrauterine growth restriction, maybe because of the multiple pregnancies and natal events, and sometimes maybe because of the operative instrumental delivery. Even during postnatal period, maybe because of sometimes because of head trauma or cerebral infections. Because of all these things, brain injury, injury to developing brain can occur at any time. And Maxelf has multiple mechanisms may underlie the neuroprotective impact of magnesium. Magnesium is a non-competitive antagonist to the glutamate NMDA receptor, can block calcium influx into the cell, can block neuronal injury. It can stabilize the stabilization of the membranes. It can increase cerebral blood flow. It can prevent large blood pressure fluctuations. It can reduce in pro-inflammatory cytokines, and it has antioxidant effects. So it has various effects, several effects which are benefited for the neuroprotection. So MaxHelp has various mechanism of actions, how it can be helpful for the neuroprotection. There are several guidelines, there are several studies which suggest the significant role of MaxHelp as the neuroprotector. Coming to our own parental body, FIGO has good practice recommendation on magnesium sulfate administration for preterm fetal neuroprotection. FIGO came out with very clear guidelines in women at risk of early preterm imminent birth from viability to 30 weeks of gestation. Use of MaxHelp for neuroprotection of the fetus is recommended. So when from viability to 30 weeks, all the fetus, all the newborn baby who are going to be delivered by all the fetus who are going to be delivered by preterm imminent birth should receive MaxHelp. MaxHelp is recommended to all such fetuses in pregnancies below 32 to 34 weeks of gestation. The use of MaxHelp for neuroprotection of the fetus should be considered. So here, FIGO has advised for the consideration, and it depends on the clinician's judgment. MaxHelp should be administered regardless of the cause of preterm birth and number of babies in utero. When birth is planned, MaxHelp should commence as close as possible to 4 hours before birth. So, even if it is delivery is imminent within 4 hours, then also FIGO has suggested the role of MaxHelp. If delivery is planned or expected to occur sooner than 4 hours, MaxHelp should be administered, as there is still likely to be an advantage for administration within this time. So it is not that only when we have 24 hours we should administer MaxHelp, but when only 4 hours are left and she is having imminent preterm birth, it should be given. The optimal regimen of MaxHelp for fetal neuroprotection is an intravenous loading dose of 4 grams administered slowly over 20 to 30 minutes, followed by 1 gram per hour maintenance dose. This regimen should continue until birth, but should be stopped after 24 hours if she is not delivered. Another guideline, another recommendation, ACOG recommendation for MaxHelp as a neuroprotection. It should be available. There are available evidences suggest that magnesium sulfate given before anticipated early preterm birth reduces the risk of cerebral palsy in surviving infants. So they have mentioned that it has significant role in preventing cerebral palsy. Magnesium sulfate reduces the risk of cerebral palsy, and that is why it should be given to all those fetuses who are having anticipated early preterm birth. Again, a guideline recommendation of MaxHelp for neuroprotection: women with preterm labor, preterm PROM, or fetal indication for delivery at 23 to 31 weeks, 6 days gestation should receive magnesium sulfate for fetal neuroprotection. Exclusions: when there is evidence of renal insufficiency or other medical conditions like myasthenia gravis, for which magnesium sulfate would be contraindicated. So except these few conditions where magnesium sulfate is contraindicated, otherwise it should be given to all the fetuses likely to be delivered between 23 to 31 weeks and 6 days gestation for fetal neuroprotection. Magnesium sulfate is recommended for fetal neuroprotection. Again, coming to a very important organization, WHO recommendation is very clear. Strength of recommendation here is strong. Magnesium sulfate is recommended for women at risk of imminent preterm birth before 32 weeks of gestation for prevention of cerebral palsy in infant and child. This recommendation applies to women carrying either singleton or multiple pregnancies. So WHO also suggested its significant role before 30 in case of imminent preterm birth before 32 weeks of gestation. So it should be given to all fetuses likely to be delivered before 32 weeks of gestation. And there are other several guidelines. We will not go in all these guidelines, but if we look at here, then all the guidelines have suggested significant role of Maxelf as the neuroprotector, and the loading dose mentioned by all the guidelines are same. Loading dose 4 gram of Maxelf slowly IV in normal saline over 20 to 30 minutes it is given. WHO has not specified the loading dose, and maintenance dose is 1 gram per hour until birth, maximum up to 24 hours is the maintenance dose by all the guidelines, may it be Australian, New Zealand, Canada, Ireland, Belgium, United Kingdom, FIGO, WHO, France, USA. Any guideline we take, all the guidelines are suggestive of the same loading and maintenance dose. But only difference is regarding the retreatment. Retreatment is possible as per the Australian, New Zealand, and Ireland guidelines, whereas other guidelines there is not they have not specified about the retreatment with the Maxel is should be done or not, and the period of the maximum gestational age is different in different guidelines, but we can say from the age of viability to all the guideline, majority of the guideline are suggestive of 31 plus 6 days means we can roughly say 32 weeks. So up to 32 weeks, all the guidelines are suggestive of use of Maxel for the neuroprotection. United Kingdom guidelines suggestive up to 33.6 may we can say, but this guideline suggests up to 34 weeks we can use Maxel for neuroprotection. So there are some clinical trials coming to the important trial conducted in India for efficacy of antenatal magnesium sulfate for neuroprotection in extreme prematurity. A comparative observational study was conducted in which 100 pregnant women who had preterm birth were divided into two groups. So in one group, intervention group of magnesium sulfate was given 4 gram IV loading dose in 100 ml normal saline over 30 minutes and preferably 4 hours prior to preterm birth, and then maintenance dose was not administered in this group, in this study, and control group there was no magnesium sulfate was given. So result was the infants who received Maxel were less likely to require invasive mechanical ventilation compared to control group. Magnesium sulfate had a protective effect on the need of invasive ventilation in preterm infants. In neonates with antenatal exposure to Maxel had more days free of respiratory support in the first 28 days of their lives, hence protecting the neonates from the adverse effects of excessive oxygenation. And we all know that excessive oxygenation can lead to retinopathy of prematurity and other complications. Another prospective RCT where 50 pregnant women who had preterm birth, a study was conducted. Again, they were divided into two groups, interventional group and control group. And dose was same 4 gram IV loading dose in 100 ml of normal saline over 30 minutes, preferably 4 hours prior to preterm birth, and maintenance dose was not given. And here the study was conducted at Raja Muthiah Medical College and Hospital Chidambaram from October 2019 to October 2021. And the inclusion criteria was all pregnant women of gestational age between 28 to 34 weeks in labor who would to deliver in next 24 hours. And the result was 60% of the newborns had normal neuronal development, whereas 30% had mild and 2% had moderate neuronal abnormalities. And the infusion delivery interval, 80% of deliveries occurred after 13 hours. So again, this suggests that a significant role in prevention of it as a prevention of neuroprotection as a significant role. And again, the Apgar score was 1 minute, at 1 minute was 5.78 plus or minus 1.64 and 77.44 at 5 minutes. About 92% of the neonates were normal. So conclusion was magnesium sulfate given for neuroprotection before preterm birth avoids cerebral palsy and lowers the combined risk of fetal infant death or cerebral palsy. Significant neuroprotective advantage to the neonates, and it is safe drug to use in antenatal women. In this, all the studies, there are no significant adverse effect were observed. Again, there was a trend towards reduced risk in magnesium sulfate group for intraventricular hemorrhage, neonatal hypotension, hypothermia, and length of NICU stay. Intraventricular hemorrhage was less frequent and less severe in babies exposed to antenatal magnesium sulfate over control group. In comparison, when Maxel was given, only 8% where fetus were having intraventricular hemorrhage compared to 16% in the control group. So there is a significant improvement in intraventricular hemorrhage incidence also. So in conclusion, magnesium sulfate is a safe drug to use in antenatal women at risk for impending preterm. Antenatal magnesium sulfate conferred significant neuroprotective advantage to the neonate. It is the time to start using Maxel in clinical practice for neuroprotective intent in all our extreme preterm births. Another prospective RCT with 1,000 plus women, 1,062 women with fetuses younger than 30 weeks gestation for whom birth was planned or expected within 24 hours were enrolled. Again, two groups, intervention group, control group. In intervention group, 4 gram magnesium sulfate was given as a loading dose. Then maintenance dose was given of 2 ml per hour for up to 24 hours. In control group, isotonic sodium chloride solution only was given. Rates of total pediatric mortality, cerebral palsy, and combined outcome of death or survival cerebral palsy at a corrected age of 2 years were studied. And what they found is in saline solution, pediatric mortality was 17.1%, whereas in Maxelf it was 13.8%. In cerebral palsy, in survivor, in saline group it was 8.2%, whereas in Maxelf it was 6.8%. Combined death or cerebral palsy was found in 24% in saline group, whereas in Maxel group it was 19.8%. Gross motor dysfunction was found in 6.6% in saline group, whereas it was found only in 3.4% in Maxel group. Combined death or substantial gross motor dysfunction 22.7% in saline group, whereas 17% in Maxel group. So the conclusion was magnesium sulfate given to women immediately before preterm birth may improve important pediatric outcomes. No serious harmful effects were seen. And Maxel, in this again very important trial, effect of magnesium sulfate on mortality and neurologic morbidity of the very preterm newborn with 2-year neurological outcome, a randomized control trial was performed. 573 women less than 33 weeks, whose birth was planned or expected within 24 hours. Again, two groups, intervention group, control group. In intervention group, they received a single injection of 0.1 milligram Maxel per liter, 4 gram over 30 minutes. Isotonic sodium chloride in control group was given. Result was decrease of all primary endpoints, total mortality decrease, severe white matter injury decrease, their combined outcome improved, and all secondary endpoints, motor dysfunction improvement was there, cerebral palsy incidence decrease, cognitive dysfunction decrease, their combined outcomes at 2 years of age in Maxel group was decreased. Result was the decrease was significant for gross motor dysfunction and combined criteria. combined criteria, death plus cerebral palsy and death plus gross motor dysfunction and cerebral palsy plus cognitive dysfunction. Conclusion given was its beneficial effects and safety. The use of prenatal low-dose magnesium sulfate for preventing neurodisabilities of very preterm infants should be discussed either as a standalone treatment or as a part of combination of the treatment, at least in the context of all these clinical trials. And meta-analysis of 5 RCTs with 5,235 patients effects of antenatal exposure of magnesium sulfate on neuroprotection and mortality in preterm infants. A meta-analysis conclusion was fetal exposure to magnesium sulfate in women at risk of preterm delivery significantly reduces the risk of cerebral palsy without increasing the risk of neonatal death. Cochrane review 2009, magnesium sulfate significantly reduces the risk of cerebral palsy in child, substantially gross motor dysfunction at 2 years of age. Magnesium sulfate had no significant effect on pediatric mortality as per the Cochrane review, means fetal neonatal later, and the number of women needed to be treated to benefit one baby by avoiding cerebral palsy is 63 as per the Cochrane review. And SOAG clinical guidelines for women with imminent preterm birth less than 31 plus 6 weeks or equal to 31 plus 6 weeks, antenatal magnesium sulfate administration should be considered for fetal neuroprotection. So what is imminent preterm birth? Imminent preterm birth is defined as a high likelihood of birth due to one or both of the following conditions: active labor with equal to or more than 4 centimeter of cervical dilatation with or without PPROM, and planned preterm birth or fetal or maternal for fetal or maternal conditions indications. So these two are the criteria from which we can identify the imminent preterm birth. We can define the imminent preterm birth, and as per this guideline, when it is less than 31 plus 6 weeks or equal to 31 plus 6 weeks, it should be given to all the mothers having imminent preterm birth. So in summary, magnesium sulfate is a wonder drug. It has many effects. Not only we all are knowing about its effects on hypertensive disorder in pregnancy and in eclampsia to prevent the convulsions, and we are also knowing its effects on as tocolytics, but it has a very significant effect even as a neuroprotection for the preterm baby. Magnesium sulfate is recommended for the neuroprotection of the fetus in women at risk of very preterm birth, and we can define how a patient who is having very preterm birth, imminent preterm birth from the definition. And there are several studies, several guidelines, all are speaking in a same direction, same language, on the same, they all are on the same page, that magnesium sulfate is recommended for the neuroprotection of the fetus in women at risk of very preterm birth. Significantly, it reduces adverse clinical outcomes in preterm birth. Significantly, it reduces pediatric mortality and cerebral palsy incidence. And we know how much it is, impact of cerebral palsy on the patient as well as on the family. And this has magnesium sulfate has a significant role in reducing the incidence of cerebral palsy also. Despite clear benefit of magnesium sulfate and despite the well-established superiority of magnesium sulfate in the management of severe preeclampsia, eclampsia, and preterm birth, it continues to be used suboptimally in India. At least it is also used suboptimally for these reasons, but it is also used suboptimally for the protection of for the neuroprotection in imminent preterm birth. It should be ready to administer solution will dissolve. A ready to administer solution will resolve the errors in dosage calculation and associated complications. It would be a welcome step if we have a saline 100 ml of saline ready with the 4 gram of magnesium sulfate, then our so many efforts will be reduced, as well as particularly solution to prepare the solution as per the proper dose will also be we can have ready solution. So thank you very much for your patient hearing. I thank you very much once again for giving me this opportunity.
Thank you,
Thank
Dr.
you so
Alpesh
much,
Gandhi,
sir.
sir. Yes, sir, please go ahead.
Yes, sir. Thank you so much, sir. I think it has been very much elaborative, and because of the time, sir could give us so much information, and that is really nice going through all the evidences, as we know. And I'm sure this is going to give us some solid as well as some important information to bring out in clinical practice. Thank you so much, sir. Yes, sir, Pratik.
So thank you very much, Dr. Alpesh Gandhi, sir, for being here with us. It's always wonderful to reconnect with you, to listen to you. I remember listening to you 15 years back when I was a youngster. You were the person who guided me actually as to how to go ahead and proxy, how to start working for committees. So hats off to you for your commitment, even
And I am
now,
happy to
15
see
years
your
later.
progress, and I am
Thank you,
also
sir.
happy to see your progress in Foxy.
Thank
You
you,
had
sir.
already reached to local joint secretary, and I want to see you even on the higher positions.
Thank you, sir. Thank you. That is so kind of you. We have Dr. Anjana Khanna ma'am with us, and Dr. Sarita Valera has also joined in. Requesting Sarita madam to please introduce.
My
Dr.
regards to
Anjana
Dr.
Khanna.
Sarita, I missed you at the beginning, and Dr. Ranjana ji, namaste.
Hello, everybody. Yes, sorry I got a little late, but I was very happy to listen to sir. And it was a wonderful talk. And I really think that magnesium sulfate has so much potential. But the difficult part is giving it through the infusion pump, giving those intramuscular injections, which are so painful. So I think that if we have this ready solution available, as you said, it will be a great advantage, and we can really give it for both neuroprotection as well as eclampsia.
It is
I
available.
also think that we are delivering babies younger and younger now. And one thing is, okay, mortality, we have taken, the neonatologists have taken care. But long-term morbidity is a big problem. And as we deliver babies more and more preterm, we really don't want to face this cerebral palsy problem, which is a disaster. Thank you very much, Pratik, for inviting me.
Yes, ma'am. Thank you so much for being here. Can I request you to please introduce Dr. Anjana Khanna, our next speaker? Madam had some difficulty in logging in earlier.
Gives me great pleasure to introduce Dr. Ranjana Khanna. Do you have Madam's CV?
Yes, ma'am, it's on screen.
Oh, I can't see it. So it gives me great pleasure to introduce Dr. Ranjana Khanna. I've had the pleasure of working with her during her vice presidential year when I was secretary of Foxy, and we really did many, many things together. She's been the founder president of ISOPA Prayagraj. She's been the president of the Allahabad Society. She has given many, many prestigious talks and many prestigious orations. She's also received national awards like the Foxy Achiever Award. And she has been a faculty at many national, international conferences. She has delivered the prestigious Dr. Prabha Malhotra oration in 2023. And I have myself written articles and chapters with Madam and worked with her. So it gives me great pleasure to welcome Dr. Ranjana Khanna for the next talk.
Thank you so much, Sarita. Now, can I share my screen?
Yes, ma'am, please go.
They'll have to remove my CV. Is it okay? Is it visible?
Yes, ma'am, it's visible. You can go full screen.
I'll have to make it full screen. Okay. It is in full screen.
Not yet, ma'am.
Now?
Yes, ma'am. Now it is. Please go ahead.
At the outset, a big thank you to Dr. Pratik Tambe, and thank you so much, Sarita, for this very warm introduction. My topic is very interesting, actually. It's preventing preterm birth Role of progesterone, cervical cerclage and pessary. Preterm labor is defined as onset of labor starting spontaneously after the gestation of viability and before 37 completed weeks of pregnancy. Threatened preterm labor is uterine contractions without any cervical change. Incidence: preterm labor accounts for 43.7% of all neonatal deaths in India. Less than 10% women diagnosed with preterm labor would actually deliver in the next 7 days. Of all the preterm births, 40 to 45 are spontaneous and 30 to 35 follow membrane rupture. Now, what is the pathophysiology? The cervix develops from the fusion and recanalization of the distal paramesonephric ducts, which is complete by 20 weeks of gestation and has both muscle and fibrous tissue. The fibrous tissue is responsible for the tensile strength of the cervix. Cervical insufficiency is related to a defect in the tensile strength at the cervicoisthmic junction. The risk of preterm delivery increases as the cervical length decreases. Hence, shorter the cervix, greater is the chance of preterm delivery. Short cervix is predictive of preterm birth. It's not diagnostic of cervical insufficiency, and many women with a congenitally short cervix would deliver normally at term. Now, what is the pathogenesis? Previous history of preterm labor or late miscarriage is associated with 32% chance of recurrent PTB. 70% of the recurrent births occurs within 2 weeks of the gestational age of the prior preterm delivery. Cervical insufficiency could be there because of cervical surgery, then lacerations during delivery, DNE, connective tissue disorders, ascending infections from the vagina and the cervix, which includes bacterial vaginosis, group B streptococcus, etc., systemic infections like pyelonephritis, pneumonia, acute appendicitis, and periodontal disease, uterine overdistension because of multifetal pregnancy, hydroamnios, causes stretching of the myometrium, initiates expressions of contraction-associated proteins. These are gene codes for gap junction proteins such as connexin 43, oxytocin receptor, and prostaglandin synthetase. They cause uterine contractions and cervical ripening. Feto-maternal stress is a very important reason for preterm labor. It causes elevation of cortisol in the mother, premature activation of the placental adrenal endocrine axis, causes increased placenta-derived corticotropin-releasing hormone, increased estrogen level accelerates the cervical ripening and leads to loss of uterine quiescence. Then there could be medical factors and there could be PROM. Then uterine anomalies could be there, like uniconvate, biconvate, septate uterus, and other causes like low socioeconomic status, anxiety and stress, tobacco consumption, substance abuse, and coitus. Now, how can you predict preterm labor is about to happen? So it can be with fetal fibronectin levels, and of course, most importantly, by TVS ultrasound. So fetal fibronectin, it's an extracellular glycoprotein. It functions in intercellular addition during implantation and placental adherence to the uterine decidua. It is normally present in the cervicovaginal secretion up to 20 to 22 weeks of gestation. Around 22 weeks, the chorion fuses completely with the underlying decidua, which prevents the fibronectin to leak into the vaginal secretions. It is not detectable between 24 to 34 weeks of gestation, though it does not have a high positive predictive value, but it has a very high negative predictive value of 99.2%. So if it is not there in the vaginal secretions, you can be quite assured that the patient is not in preterm labor. Now, coming to the transvaginal scanning, funneling of the cervix with changes in the forms T, Y, V, U. See, this is learned by a mnemonic, trust your vaginal ultrasound. So in the T, you have just the opening of the internal os, and then it goes on to the funneling of the cervical canal till finally it opens and the external os is about to open in this picture. Cervical length less than 25 millimeter is quite indicative that the patient could be going into preterm labor, protrusion of membranes, and presence of fetal parts in the cervix or vagina. Now, for treatment, the simplest way to effective surgery, just choose the right patient to do your surgery. So coming to McDonald stitch, that is the most commonly used transvaginal cerclage, first performed in 1963 by using a permanent suture. In this, we take with the Babcock forceps, we grasp the anterior lip of the cervix and take purse string sutures to try to take it as high as possible in the anterior part, and then just take a purse string and tie it tightly. The knot should be tied tightly and it is placed anteriorly. So this is removed either at the onset of labor pains or at 37 weeks. Then we have a high cervical cerclage Shirodkar stitch, which was reported in 1955 by Dr. V. Shirodkar, an Indian obstetrician. Many modifications of this has been made in the original technique. He used a strip of fascia lata, 1/4 inch wide and 4.5 inch long, which he removed from the outer aspect of the thigh. And to both sides, there was linen suture attached. So this is put on a Mayo's needle. Nowadays, we are using Mercilin tape. So in this, we make a transverse nick anteriorly, push the bladder up so that we can go as high as the internal os. And then with the Mayo's needle or, something like an aneurysm needle, initially it was known as Shirodkar's needle. And we take a stitch which goes from the anterior to the posterior, and posteriorly we have a vertical nick. So we take it out from there and then again from posterior to anterior and tie a knot over there. And this is very effective in actually in cases of prevention of preterm labor. Now, what are the guidelines, RCOG guidelines regarding cervical cerclage? So there could be a history indicated cerclage should be offered to women with 3 or more previous preterm births and or second trimester losses. This is a level B evidence, should not be routinely offered to women with 2 or fewer losses. So please remember that if there are lesser losses, we don't need to give a cerclage. USG indicated cerclage is not recommended in women without a history of spontaneous preterm delivery who have an incidentally identified short cervix of 25 mm. So if you accidentally find it and there's no history of prior preterm labor, you need not give a cerclage. A history of 1 or more spontaneous mid-trimester losses or preterm births who are undergoing TVS surveillance of cervical length should be offered cerclage only if the cervical length is 25 mm or less before 24 weeks of gestation. This is a level A evidence. And ultrasound indicated cerclage is not recommended for mere funneling of the cervix if the cervical length is more than 25 mm. So coming to the serial sonographic surveillance, women with a history of spontaneous preterm delivery can be offered serial sonographic surveillance because those who experience cervical shortening are at an increased risk of subsequent mid-trimester loss or preterm labor and may benefit from cerclage very unlike those whose cervix remains long. But women should be informed that if you're not able to do a sonographic surveillance, then you can actually just wait and watch. Transabdominal cerclage is normally done in those patients in which the transvaginal fails. Rescue cerclage. Now, this is a very difficult condition in which the patient has already gone in preterm labor. We need a senior obstetrician for this. And normally what the internal os is already open, the external os is also open, and you can sometimes see the membranes also bulging. So what is done is that the patient is placed in the extreme Tredelenburg position with the head end low, and then we pass a Foley's bulb inside through the os, and then we gradually inflate it. So when you are inflating the bulb, the membranes, bag of membranes is gently pushed out from the view. And then we can apply the McDonald stitch, but be very careful while applying that gradually deflate the Foley's. Otherwise, you'll end up pricking that and including that in your suture. So, but in this case, if the dilatation of the cervix is more than 4 centimeters or the membrane prolapse is beyond the external os, and this appears to be associated with a high chance of cerclage failure. In multiple pregnancies and uterine anomalies, cerclage is not routinely recommended. So what are the contraindications? Active preterm labor, clinical evidence of chorioamnionitis, continuing vaginal bleeding, PPROM, evidence of fetal compromise, lethal fetal defect or fetal death. Complications would be membrane rupture, preterm labor, hemorrhage or infection. These are, however, uncommon with prophylactic cerclage. There is no role of perioperative antimicrobial prophylaxis and procolysis. Now coming to the next part, the cervical pessaries. Most commonly used is Arabin. This is very frequently used, but in India also we've started using. And others that have been used are ring pessary, Hodge and donut. The mode of action is that it presses the internal os closed from behind, changes the inclination of the cervical canal, so the uterus becomes anteverted and is gravid uterus. All the weight falls on the anterior segment and it is not there on the cervical canal now. And it protects the cervical mucous plug, thereby preventing ascending infection. Arabin pessary is round, cone-shaped, flexible silicone pessary, dome-shaped, resembles the vaginal fornices, hence it encircles the cervix. Has perforations in the silicone for drainage of vaginal discharge, comes in different sizes. It has to be lubricated, squeezed between thumb and finger, and the smaller part goes in front, and then you go and completely encircle the cervix. So something like this it fits in. So the Arabin pessary goes right inside and it encompasses the whole cervix inside that. So it is clamping on the cervix. It's absolutely atraumatic and the removal can be done very simply. So it unfolds inside with the smaller inner ring facing towards the cervix. The dome is pushed towards the fornices until the cervix is completely surrounded. Cervix should protrude through the inner ring. And it is removed at 37 weeks, or if the delivery is imminent, if contractions are effective, cervix is pushed back through the inner ring and the Arabin pessary comes out easily. The results of the pessary, several studies have been done and they say that the results are quite good. Advantages, it is non-invasive, no anesthesia is required. There's no foreign body inside the uterus, reduced risk of infection, no effect of tearing of cervical tissues by contraction, no pressure necrosis of tissues under the suture, changes the uterocervical angle. So direct pressure is on the anterior segment, as I've told you, that the uterus falls anteriorly. So prevents direct pressure on the membranes, protects the cervical mucous plug, so less chances of ascending infection, may be left in situ in case of rupture of membranes on conservative management. Very easy to remove. Now coming to what we are doing in our daily practice, vaginal progesterone. Progesterone, we know, has an essential role in maintaining pregnancy, primarily through establishing uterine quiescence. This is achieved through suppression of the calcium, carmodium, myosin light chain kinase system, reducing the calcium flux and altering the resting potential of the smooth muscles. So what is the mechanism of action? It acts at various sites. So at the placenta, it regulates the timing of labor via controlling the stress hormone. In amniotic fluid, it limits the prostaglandin production. At the fetal membrane, it blocks the pro-inflammatory cytokines, induced apoptosis, preventing PROM. At myometrium and cervix, it suppresses the inflammatory response. Which progesterone? We all are familiar. There's oral progesterone, sustained release 300 milligram tablet. Then there are the pessaries, the soft tablets which we have. Then we have the gel. Injections are there, 17-alpha-hydroxyprogesterone caproate, and which is given weekly, and injection, natural micronized progesterone, which is given every third day. What are the international guidelines? French guidelines 2016 say that if the cervical length is less than 25 mm, it's undilated os. Then vaginal progesterone, either 90 milligrams gel or 200 milligram pessary. and duration 24 weeks to 34 weeks. It's level A evidence. And FIGO 2015 guidelines are practically the same till 34 weeks. And Strategy 2015, they recommend giving the vaginal progesterone till 37 weeks. ACOG says vaginal or intramuscular progesterone from 16 to 34 weeks, and SOGC is also of the same opinion. So with vaginal progesterone 2015, we can use it for prophylaxis of preterm birth. This is updated data of 2019. It is offered to patients with history of prior preterm birth less than 34 weeks and mid-trimester losses and or results of TVS at 16 to 24 weeks of gestation shows a short cervix. Now, Society for Maternal Fetal Medicine 2017 said that in a woman with a singleton gestation and a history of prior spontaneous preterm birth between 20 and 36 weeks of gestation, we recommend 17-alpha-hydroxyprogesterone caproate starting at 16 to 20 weeks till 36 weeks of gestation or delivery, and vaginal progesterone should not be considered a substitute for this in these patients. Now, when we talk about twin gestation, vaginal progesterone decreases preterm birth and neonatal morbidity and mortality in women with a twin gestation and a short cervix. An updated meta-analysis of individual patient data was done, and the conclusion was that administration of vaginal progesterone to asymptomatic women with a twin gestation and a sonographically short cervix in the mid-trimester reduces the risk of preterm birth occurring at less than 30 to 35 weeks of gestation, neonatal mortality, and some measures of neonatal morbidity without any demonstrable deleterious effects on childhood neurodevelopment. This was published in 2017, and it's a US government work. So, the use of progesterone for prevention of preterm labor. Vaginal progesterone and cerclage are equally effective for preventing preterm birth and improving perinatal outcomes in women with a singleton gestation with previous spontaneous preterm birth. The choice of treatment will depend on adverse events and cost effectiveness of intervention and patient and physician preference. A randomized trial of oral micronized progesterone, 400 milligrams OD for prevention of recurrent spontaneous preterm birth showed a trend towards reduction with increase in maternal serum progesterone levels. Now, progesterone as an alternative to cervical cerclage, an Indian experience. Pregnancy outcome in short cervix was done. Progesterone versus cervical cerclage. So 50 patients were taken, 25 were kept on vaginal progesterone and 25 were applied cerclage. Now, what was the result? Conclusion was that NMP is as effective as cervical cerclage in prevention of premature labor in a woman with singleton pregnancy with a short cervix. Use of NMP is preferred because it is non-invasive, easy to administer, patients do not suffer from surgical and anesthesia-related adverse effects, and it is not associated with any hospital stay, very economical, so it's good for both the doctors and the patients. Dafoniska in 2003 did a study, 142 women with prior preterm births and or prophylactic cervical cerclage, uterine malformations. They were given 100 milligram progesterone suppository with a blind placebo trial. The same investigators in 2007 studied 413 women with a short cervix and gave 200 milligram progesterone suppository. They found a significant reduction in the preterm birth in the progesterone group. No RCT, however, has directly compared head-on vaginal progesterone and cervical cerclage in cervical insufficiency. 4 studies evaluated vaginal progesterone versus placebo, and 5 studies evaluated cerclage versus no cerclage, and they showed a statistically significant reduction in the risk of preterm birth. Eferivic et al. In 2013 compared 2 cohorts of women with previous preterm births and a short cervix. 142 women with cerclage, 59 women with vaginal progesterone. They found no significant difference in terms of perinatal loss, neonatal morbidity, or preterm birth, but there was a higher rate of birth before 34 weeks in the vaginal progesterone group as compared to the cerclage group. So now what are the FIGO guidelines? They say that sonographic cervical length measurement should be performed in all pregnant patients 19 to 23 weeks of gestation by TVS at the same time as level 2 scan is being done. Women with a sonographic short cervix less than 25 mm diagnosed in the mid-trimester should be offered daily vaginal micronized progesterone for the prevention of preterm birth and neonatal morbidity. The progesterone formulation, they recommend NMP, either the soft capsules 200 milligram nightly or the gel 90 milligrams each morning. Universal cervical length screening and vaginal progesterone treatment is a cost-effective model for preventing preterm birth. So what is the evidence on which FIGO recommendations for progesterone prophylaxis in women with a short cervix are based? To address this question, it is necessary to consider the efficacy of progesterone, impact of such a strategy on a population basis, and long-term benefits and harmful effects of progesterone treatment in pregnancy. So a prolonged trial was done. Published in October 2019, no significant change on the rate of preterm births or neonatal morbidity in the groups comparing the patients treated with 17 OHP against patients giving placebo. Optimum study compared vaginal natural progesterone versus placebo in the outcomes of improving the obstetrical outcomes by lengthening the pregnancy and the neonatal outcomes, and they found to have no significant effect on any of the primary outcomes. Moreover, subgroup analysis of women with a short cervix showed no significant interaction between cervical length and outcome. In other words, women with a short cervix did not respond better or worse to progesterone as compared with any other woman in the study. So there was this progress study, compared the outcome of randomly divided patients managed by vaginal progesterone versus placebo. There was no difference in the primary outcome, that is the incidence of RDS in newborns. So to conclude, the National Institute of Clinical Excellence in the UK, FIGO and SMFM in US all recommend the use of progestogens for women at high risk of preterm birth. The latter advises, that is the Society for Maternal Fetal Medicine, that women between 20 to 36 gestational weeks receive 17 hydroxyprogesterone caproate, 250 milligrams IM weekly, starting at 16 to 20 weeks till 36 weeks, or delivery for women with a singleton gestation and a history of prior spontaneous preterm birth. The two former organizations endorse the use of vaginal progesterone for women with a short cervix. ACOG Practice Advisory, this came out in April 2023. There was not sufficient data to indicate 17 hydroxyprogesterone caproate as an effective treatment in all pregnant women with prior spontaneous preterm birth. Whether this treatment would benefit a subset of women requires further study. FDA decision is not based, however, on safety concern. NMP is as effective. So to conclude this problem, NMP is as effective as cervical cerclage in prevention of premature labor in a woman with singleton pregnancy with a short cervix. Cervical cerclage showed more benefits than vaginal progesterone for women with an asymptomatic short cervix prior preterm birth history, while cervical cerclage and vaginal progesterone showed similar effectiveness for women with a short cervix, but without a history of PTB. So if there is a previous history of preterm birth, it is better, and the cervix is short, it's better to give cerclage. But if there is no previous history and just a short cervix, and it seems as if she can go into preterm labor, then it is they are equally effective. You can give either vaginal progesterone or cerclage. Use of MNP is preferable in clinical practice because, as I said before, it's non-invasive, easy to administer, and patients do not have any anesthesia or surgical related adverse effects. Thank you so much.
Thank you, Dr. Ranjana Khanna ma'am, for joining us and that very exhaustive presentation on how to prevent preterm labor, including the evidence-based dissection of which is better, whether it's natural mechanized progesterone, real progesterone, whether it is cervical suckling, how to actually go about performing a cervical suckling. In fact, I think in my entire lifetime, I've seen only one rescue suckling. It was performed when I was in Badia 25, 30 years back. It's
You all are
something which
I put lots of circlades.
in our practice, usually what happens is patients are put up with a cerclage right at 14 to 16 weeks, textbook style. Very rarely do they come up for rescue cerclage in our setup now, because we have excellent follow-up most
I
of
have
the
seen
time.
my professor even perform Shirodkar, though I
Okay.
only give McDonald.
No, we perform Shirodkar routinely, ma'am. In Mumbai,
Okay,
we are
using
very much biased towards.
McDonald.
No, we're very much biased towards Shirodkar because this is the birthplace of the Shirodkar
Yeah.
stage. But it took me down memory lane to see how things have evolved. How previously we used to do a history indicated supply. Now we are going more into evidence-based medicine. We have
Yes.
ultrasound indicated cerclages. And some of the older techniques which were advised are maybe dying away. We are not passing them on to our juniors. But
Yeah.
with senior OBGYNs and reputed teachers like you who are carrying the torch forward, I think we will continue to have a proper
Yeah.
way
I
of
think
teaching.
obstetrics has become a dying art now, is becoming rather.
Absolutely,
We should try
absolutely.
to save it because everybody, all the PGs are going towards reproductive. It's always, reproductive or fetal medicine. That's
Just
it.
couple of days back, I was saying, ma'am, that with IVF specialists creating more and more pregnancies in
Yeah.
high-risk women with lot of comorbidities, many of whom are elderly, and they have silent issues which are not diagnosed. Again, high-risk pregnancy and obstetrics is going to become a super specialty. People like you and I are going to be in demand.
Of course.
It's not a dying art. It is going to get revived very soon.
I
Once
hope,
all
because
these patients get
it's really
pregnant.
very dear to me. Obstetrics is my passion, actually.
Absolutely, absolutely. So it's wonderful to have you with us, ma'am. And we had a fantastic talk from Dr. Alpesh Gandhi, sir, as well. We had to switch the order of the speakers because madam was facing some technical issues, but that would have been a perfect progression. You talking about prevention, setting the stage, and then he talking about teaching you.
Yeah.
It was lovely to have both of you today. We have a couple of questions which have come in, but I think they've been answered through these two wonderful talks by these two senior and dynamic proxy vice president and president, respectively. There was one question regarding fetal neurodevelopment and how does smoking and alcohol during pregnancy affect it. Probably this is something which is coming forward more
Yeah.
because in the metros now we find that women are also smoking with the fast changing culture and lifestyle, maybe
Yeah.
alcohol and smoking in pregnancy is becoming more common in the metro cities. So alcohol is well known to be associated with something called as the fetal alcohol syndrome, which results in microcephaly, results in stunted brain development. These babies can also, once they are born, you'll find that their IQs are significantly hampered. And smoking, of course, causes fetal growth restriction. It causes placental infarcts. It can result in sudden IUFDs. All of these issues are quite well known. The second question I see is regarding the ready-made dosage, which Dr. Alpesh Gandhi was speaking. So here I have to acknowledge the role of our educational partners, Listen Pharma. They've come out with a ready-made, easy-to-administer solution, 4 grams of magnesium sulfate in 100 ml, and it's called ID-MAG. It's readily available throughout the country. And even for paramedical staff, where they may have difficulty understanding dosing, dilution, 25% or 50%, how to get, it's very easy. It's a ready-made 100 ml pint, as sir showed in his presentation. You just administer it slowly over 15 to 20 minutes. That's the loading dose, and you can give 1 gram per hour for the next 4 hours, and that covers the patient over the next 16 to 24 hours. It's very easy. You may not even need an infusion pump because administration is so easy, especially in periphery where you get eclamptics.
Yeah.
Magnesium sulfate is still the drug of choice in eclampsia. This is going to be a boon because even paramedical personnel or the doctor is not present in a primary health center, for example, can administer it very easily. That's the end of the relevant questions. I'm very happy to announce that we have an audience of about 900 delegates who are logged in across the length and breadth of the country. So thank you very much, delegates, for being here with us. Dr. Alpesh Gandhi sir has joined in again. Thank you, sir, for being here with us. Any closing remarks, any messages you would like to give the audience before I declare the formal vote of thanks, sir?
Preterm labor is as much a menace for us as it is for the neonatologists, because
Absolutely.
they are the ones who have to actually handle the babies. So they are more scared of it than probably us. We try our best. We give antenatal corticosteroids. We try to at least do the lung maturity. And sometimes I've seen that the children don't have to go to NICU at all. So if we have done our bit, then I think it becomes easier for the pediatricians also.
I think it makes their life much easier, and we have to understand that not throughout the
Yeah,
country everybody has good NICU setups.
yeah,
It's only in metros and good tier two cities.
yeah. We've got good ICU setups, but if we do our bit about trying to prevent it as much as possible, giving antenatal steroids, giving magnesium sulfate, then I think it makes life easier for the NICU people also.
Thank you. Alpesh Gandhi sir, any closing remarks, sir?
Always it is important to identify high risk factor, high suspicious, high prediction, high efforts for prevention. So suspicious, prediction, prevention, always very, very important. And the role of for preterm, of course, role Dr. Ranjana ji has nicely mentioned about all the management aspect. But the role of Maxal, role of steroid are very, very important. And again, role of vitamin K. So these all are very, very important. Our job is to extend as much as possible, prolong pregnancy as much as possible. And with all these measures, I think nowadays preterm delivery is incidence is decreasing day by day. But at the same time, the morbidity should not be increased. Morbidity in the sense long-term sequelae should not be there. Our role is not only to see that mortality is decreased. We after giving live child, our main motto should be to give live as well as a healthy child.
And
And
to give a
healthy
good
means
quality of life
physically
to
as
that
well
child.
as physically, mentally healthy quality of life. So both the things are very, very important. Our role is very important, significant, and this is not a rocket science, but we need to be we should be alert, we should be updated, we should accept all these newer developments, newer technology, newer molecules for the benefit of our patients and newborns.
Thank you, sir. I think those are very wise words indeed. So I'll conclude today's program, the Fetus in Focus, part of the TOG Experience series, by offering my gratitude to our chairpersons, Dr. Sarita Balera and Dr. Hafizur Rahman. Two fantastic talks by Dr. Alpesh Gandhi sir and Dr. Anjana Khanna. Thank you so much for gracing the occasion, taking time out despite your busy schedules. I also need to thank the Science Integra backend team, Subbu and Shrutika, who is here. Thank you so much for being there as our scientific support. And last but not least, our academic partners, listen, who are makers of IV-MAG injection I3, that is iron isomaltoside, and carbazin, that is heat stable, room temperature stable carbetocin for prevention of PPH. Thank you very much for being our academic partners in this journey. Thank you, audience, for logging in. We have over 900 delegates throughout the country. We hope to see you again at the next event very soon. Until then, goodbye, God bless, and bye.